Hi everyone, my name is Vikas Shah. I'm a consultant radiologist in Leicester, and this talk is Introduction to Abdominal CT. I've prepared this talk using a playlist from Radiopedia, and you'll also have received some links to further reading on the Radiopedia website, where there is a whole heap of freely accessible material, including articles, learning cases, and some review questions as well. So the objectives of this talk are to think about how we do CT of the abdomen and pelvis, and in particular looking at contrast and the different phases of contrast enhancement. So we'll look at when we do a non-contrast CT and what the limitations of this type of CT are, and then the different routes of administration of contrast media for CT of the abdomen and pelvis. And in particular, when we administer the contrast intravenously, what are the different phases of contrast administration, such as arterial and portovenous phase, and when we use them. And finally, understand the clinical actions that you need to undertake when you're referring a patient for a contrast-enhanced CT of the abdomen and pelvis. So, as a radiologist, one of the most important things when reporting CT of the abdomen and pelvis is to understand the anatomy. And I'm going to send you a link to this particular case on Radiopedia, which is an annotated CT, annotated and labeled, showing the various normal anatomic structures and then what particular abnormalities we look for with regards to those structures. So, for example, at the very top of a CT abdomen and pelvis, we see the pleura, and we look for effusions, thickening, plaques, and nodules. And as we scroll down, then we see that all of these different structures are labeled. And really, understanding the normal anatomy is key to then being able to decipher abnormalities and disease on clinical CT abdomen and pelvis. So, in this particular case, we've got all of the axial images with lots of different labels and annotations. There's a coronal series as well, so you can see all those different structures in this particular view. And there's also a bone window to show the different bones that we encounter on a CT abdomen pelvis. So I'd encourage you to have a look at that at some time. So let's start by looking at this CT, which is a non-contrast study, and it's known as a CT-KUB, which stands for kidneys, ureter, and bladder. And this is a study that's done to look for renal or ureteric stones. And I've got another example I'm going to show you in a little while. But what I want you to observe on this CT is that when we look at the abdominal viscera, so here we've got the liver, the kidneys on both sides, the spleen, the pancreas. This is a bit of bowel. And what we notice is that they've all got a fairly homogeneous, bland, greyish appearance to them. And it's very difficult to differentiate structures within the organs, such as the vessels within the liver. Difficult to differentiate the cortex and medulla of the kidney. And then as we scroll down, we see that bowel loops all look the same. The vessels look the same, lymph nodes, and everything's got this kind of very bland appearance to it. Now, on this non-contrast CT, essentially there are four densities that we can appreciate. So first there is air, which is this very low density. It's very dark, so it's low density. Then there's the intra-abdominal and subcutaneous fat, which is this dark grey kind of appearance here. And then there's all the soft tissue. So that includes the muscles, so the abdominal wall muscles, the psoas muscles, paraspinal musculature, and all the intra-abdominal viscera all have this grey appearance. And then the most dense is the bones. Here we see the vertebral column. And we see those four separate densities. Now, when we give contrast, then things look different. So just a quick note on contrast. Contrast media contain iodine, and the way that the physics of the CT scanner works is that the iodine is shown to be very dense on CT, which means it's very bright white. So whichever structure contains the contrast has a high density So in this case, the aorta and its branches contain the contrast, so that they're very densely pacified is the phrase that we use. So they're very bright white on the CT. So the contrast here has been injected intravenously. Now you just have to map out a visual journey in your mind about how this contrast has reached here. So from the injection into a peripheral vein, typically in the antecubital fossa, it travels into the superior vena cava, right atrium, right ventricle, through the pulmonary circulation, so the pulmonary arteries, the pulmonary microcirculation, pulmonary veins, then into left atrium, left ventricle, and then aorta, and then it will be within the arterial system of the body. And that whole journey takes roughly 30 to 40 seconds. So if you hit the go button on the scanner at approximately 35 seconds after the contrast has been injected, then this is the type of study you'll get, where the contrast is maximally present and most dense within the arterial vessel. So the aorta, the celiac axis, the superior mesenteric artery coming off just anteriorly there, and then the right and left renal arteries. Now, if we were to then hit go on the scanner again at approximately 70 seconds, so that's 70 from the time of the contrast injection, then the contrast has had time to go through the tissues of the lower limbs and back into the systemic venous system. And so it's in the iliac veins and in the inferior vena cava, which is just here, and also make its way through the bowel and then into the mesenteric venous system, and then from there into the portal venous system. So this here, I'll just get to that. This is the portal vein. This structure here is the portal vein, which you can see is now got more density within it because there's contrast in there. And this is the inferior vena cava. So let's compare that to the equivalent slice on the arterial image. You can see that on this image, the aorta and its branches are the most dense, whereas the IVC doesn't look as dense, whereas now you can see that there's more density within the IVC and the portal vein, indicating that this is a portal venous study, simply done by acquiring the scan at a later time point after the contrast has been injected. So when we're thinking about contrast, the different routes are intravenous, which is by far the most common, but also we can administer contrast orally through the rectum and also into the urinary bladder. And when we think about the phase of this study, then if you don't administer any contrast, or certainly no intravenous contrast, then we call that a non-contrast study. But when intravenous contrast is administered, then we can acquire these different phases, as we've already seen: systemic, arterial, portal venous, and delayed. Now, the delay can vary greatly depending on what particular information you wish to acquire from the study. And I'm going to show you a couple of examples of delayed studies. So what you need to think about when you're referring a patient who may have a CT with intravenous contrast is whether or not they've got any known allergies, and these need to be documented clearly on the request. You need to give the EGFR, and I'm going to explain that in just a moment. And you need to make sure your patient's got good venous access, ideally a pink size working cannula. So the reason that we ask about the EGFR is because historically there's been concern that intravenous contrast, when administered to patients who are already have gotten impaired EGFR, may permanently and irreversibly reduce their EGFR a little bit more by causing renal damage. And this used to be known as contrast-induced nephropathy. However, there is a growing body of research that indicates that this is an observational effect rather than an association. And so the most recent term given to this is post-contrast acute kidney injury, reflecting that we know kidney injury happens after the contrast has been given, but we don't necessarily believe that it's a cause and effect. What most people think is that the contrast is given to people to scan them when they're very unwell and septic, and it's that septicemia that's actually driving the reduction in EGFR rather than the contrast itself. But the best evidence we have is from retrospective observational studies rather than any prospective study. So the pragmatic approach is that the EGFR needs to be over 30, in which case everything's fine. If it's under 30, think about whether or not imaging is needed at all, whether another modality could be useful, for example, ultrasound or MRI, whether the contrast, whether the CT could be done without contrast, and whether that will give us the information. But if the contrast is very important and it would be a life-saving study, then we just go ahead and give the contrast. So let's start looking at some examples of different phases. So let's start with a non-contrast CT. And the most typical example of this is a CT KUB, which is the one I've said already, is for looking for renal stones. So the reason we don't need to give contrast is because stones are dense because of the calcium content. So they'll stand out within the soft tissues when we see them. So as we scroll through this, I can see that there are already signs here involving this left kidney that there's going to be trouble further down. The pelvic ileocecal system is slightly full compared to the right side. The left ureter is distended when compared to the right ureter. And I can follow that down the retroperitoneum. It continues to be distended. And as we reach the urinary bladder, we see that there is an obstructing stone there sitting within the ureter just proximal to the VUJ. So that stone will pass through into the bladder, but in the effort the ureter is making to pass that stone through, that's causing the patient to have waves of colic. So contrast is not really necessary because we can see that stone here very dense on this type of CT. Now, sometimes we would like to give contrast, but we can't because a patient may not have venous access. Maybe they're allergic to contrast. But there are situations in which doing a plain CT will still be useful. So this patient had severe acute abdominal pain, was hypotensive, tachycardic, and what we see is that there is heavy vascular calcification of the abdominal aorta and its major branches. But more than that, there is an aneurysm of the abdominal aorta, and there is a lot of high density material here filling the right retroperitoneal compartment and displacing the right kidney. This is hematoma, and this is because this abdominal aortic aneurysm has ruptured into the right retroperitoneal compartment. So even doing a non-contrast study with all its limitations can still allow us to make that diagnosis. Sure, on this study we don't have great detail given to us about what's going on in the kidneys and any small focal lesions there might be, or the detail of what's going on in the liver, but it's given us enough information to at least proceed to some sort of emergency treatment for this patient. Now, if we were to administer intravenous contrast, the most common type of study we do is in the portal venous phase. This is by far and away the most commonly used phase for most acute abdominal CT and also for a lot of outpatient work as well. And that's because this provides us the optimal enhancement for the abdominal viscera for general purpose work. So this is an acute abdominal CT. This is someone with right iliac fossa pain, and we can see that there's contrast within the iliac vessels and the iliac vein and arteries here. And on the right side here, we've got the ascending colon. And as we scroll down, we get to the tip of the cecum, and then there is this structure here, which is elongated, tubular, thick-walled, and with a greater density in its wall than would be expected. So this is an inflamed appendix with a thickened wall with a hyper-enhancing wall. And what hyper-enhancing means is that there is contrast being taken up by the wall because of the inflammatory process happening within the appendix. So the contrast here has helped to increase our confidence of making the diagnosis of acute appendicitis. Another feature here that's contrast independent is fat stranding. You'll come across this phrase when you're looking at CT reports. So look at this. This is normal intra-abdominal fat, this corner here, this tissue, this black tissue. And this tissue here next to the appendix, this is inflamed fat. It's got a greater density. It's gone towards a whiter shade because of the inflammation. And that's a really useful sign to look at. The coronal view here again shows that really abnormal appendix, which is much easier for us to see because of the contrast. We can see that the appendix is thick-walled and that the density of the wall is greater than we'd normally expect. And that's something that radiologists get their eye in for quite early in their training, to look at the density and see whether or not it's greater than they'd expect. Another interesting finding in this scan is this very, very dense structure near the tip of the appendix. This is an appendicolith, which is a small calcified stone, maybe a small calcified bit of feces that gets trapped within the lumen of the appendix and is often found on imaging of appendicitis. And it's postulated that this obstructs the lumen and therefore leads to inflammation of the appendix. So one more example of a contrast enhanced portovenous phase CT. This patient had lower abdominal pain with localized left iliac fossa tenderness. So I'll just go down to the lower abdomen, and what we'll observe is that in this patient, the sigmoid colon, which is this bit of bowel here, is very thickened and inflamed, and the wall is thickened. And giving the contrast enables us to really accurately delineate the wall from the lumen and what the thickness of the wall is. We also see numerous pockets containing gas arising from the sigmoid colon, and these are diverticuli. The fat next to the sigmoid colon is of increased density, so that's that fat stranding sign we talked about. So all of this adds up to acute sigmoid diverticulitis, a quite common emergency presentation for a lot of people. But in addition to all of those, there's something else that CT is really useful for looking at. There are numerous small pockets of gas, such as this one here, which are outside of any recognized bowel. And the more you look, the more you see. And then look just here deep to the umbilicus, there's quite a big pocket. And in the epigastrium, there's a lot. This is all free gas. So there's a pneumoperitoneum. So not only is this acute sigmoid diverticulitis, there's also perforation with a pneumoperitoneum. So those are two cases of acute abdominal inflammation. One was appendicitis, one was diverticulitis. This patient presented with features of bowel obstruction with vomiting and abdominal distension. And again, it's a portovenous phase CT. We see enhancement to the liver, so it's a greater density than we'd expect with a non-contrast study because the iodinated contrast media has entered the liver. So overall, the density that we see is greater than normal. There's contrast within the vessels, so we see the portovenous branches. We can delineate them very clearly. We can see the hepatic veins as well. And as we scroll down, we see that the bowel loops are distended. So the small bowel loops here are distended and fluid filled. So I have a 3-tiered approach to CT of bowel obstruction. Number 1, confirm there's bowel obstruction. Number 2, define the cause of the bowel obstruction. And then number 3, look for complications. So number 1, there is bowel obstruction here. Yep, fine. Number 2, we have to try and find the cause. So we can scroll down and we're looking for a transition point. That's where the bowel goes from being distended to collapsed. So keep an eye on this particular bowel loop here. It's getting very narrow. It becomes very tightly pinched down, and then it opens up again. And if we look at the coronal views, these are really helpful. You can see there's that bit of bowel that's coming down and then pinched and then opens up here, which is the femoral space. So this is a femoral hernia with tight pinching of the bowel at the neck causing obstruction, and all the bowel that's coming out of the hernia sac and then heading towards the cecum is collapsed. So that's the downstream limb, but everything upstream from this is very distended. So this is a femoral hernia causing bowel obstruction. In terms of complications, contrast is helpful, because I'd be looking at the enhancement pattern of the bowel wall to see if there's any features of bowel ischemia, which there aren't in this case. We'd also look for the presence of free fluid and for signs of perforation. Let's look at arterial phase studies. So we've already seen an example of an arterial phase study, and you can see how the contrast was very dense within the aorta and its branches. And that's used by my vascular radiology colleagues for looking at abdominal aortic aneurysms, for looking at aortic and iliac stenoses or pseudoaneurysms. And with the data that we get from the CT studies, what we can do is run it through some software that picks out the highest density areas and converts it to an image like this, which provides a roadmap of the vessels in a 3D format. And this then allows us to plan procedures for implementing devices within the vessels. And it's quite useful to be able to rotate these images and look at them in different angles. Another use of arterial phase CT, when it's complemented by portovenous phase CT, is to look for areas of bleeding. So this is a multi-phase study. So this patient has been given contrast. This is an arterial phase study, and we can see that this is a normal right kidney on this side, and on the other side, this is a markedly displaced left kidney, displaced anteriorly, because there is a very large hematoma arising from the surface of the kidney, and also there is a lot of blood here behind the perinephric compartment in the retroperitoneum. And what we notice is that there are high density foci of what we call contrast blush, just immediately adjacent to the kidney, just there, and slightly lower down. Now, when we look at the portovenous phase, so once again, it's just one dose of contrast that's been given, but the patient is scanned at 35 seconds for this one, and then at 70 seconds for this one. What we can do is look to see what's happening to those blushes of contrast, and we can see that this blush here becomes slightly larger, and then lower down, these blushes here are also just ever so slightly larger than on the arterial phase study. And what that indicates is that this is contrast extravasation, and this contrast is spreading out with the passage of time, and it's doing what blood would do. So we can track what blood is doing by looking at the contrast. And so this patient is actually actively bleeding during the scan. This contrast shows us that the blood is actively oozing out into this space as we're scanning them. And so having this information, first of all, confirms that there's active bleeding, so something needs to be done. Second of all, having this arterial anatomy provides a really great roadmap of the vessels for the interventional radiologists. So they know, for example, that the groin vessels might be suitable for access for an angiogram, an angioplast, a procedure for access to the vessels to then embolize whichever vessel might be bleeding here up in the adjacent to the kidney. Now let's look at some examples of delayed phase imaging. And as I've already said, the time that the delay that you put on the scan can be varied depending on what specific information you require. So this is really useful for urological imaging, because when the contrast is injected, you can allow the kidneys to handle the contrast by allowing it to pass through the tubules, and then it gets excreted into the pelvic calyceal system and then into the ureters. So we can see here that contrast has been allowed to pass into the ureters. Now you need to wait about 7 to 10 minutes after the contrast has been injected in order to allow this to happen. And once the ureters are distended like this, it's really easy to look for small filling defects or polyps arising from the urothelium. So in this case, we've got really nice filling of this right pelvic calyceal system and the right ureter. So this woman had intermittent microscopic hematuria, and we can follow the right ureter and see it's got a nice normal path, no filling defects. It's passing down the retroperitoneum and then eventually into the urinary bladder. On the left side, however, the there's no filling defects, but there is slight distension of the pelvic ileocecal system, and the left ureter as well is slightly distended when compared with the right side. But if we follow the ureter down, it doesn't really follow the path we'd expect. As we get down, it kind of deviates laterally and then heads out into this space here. And so this is a hernia, a quite uncommon hernia, sciatic hernia, where the ureter is trapped within this tissue space. And that's why there's upstream obstruction of the ureter. And just like we saw with the arterial phase study, this data can be manipulated to present it in different ways. So here, this looks like a virtual old-fashioned urogram that we used to do, where you can see the path of that very distended ureter. You can present that using color if you like, and we can also present that as a rotating movie to show this anatomy in 3D, to show where that ureter is heading out of that sciatic notch to cause that hernia. Sometimes we give the contrast orally, and we do this in particular to look for specific leaks from the GI tract, or if we're looking for a fistula, say between the bowel and the skin. So that's an enterocutaneous fistula. And we do these kinds of CTs a lot for the upper GI team. So this patient had a gastric pull-up. So that's when an esophagectomy has been done and the stomach has been pulled up into the chest. But unfortunately, sometimes there are leaks from the staple lines, which happened in this case. And this was not the first scan this patient had. They've had a tube inserted into a hole in the staple line that was previously identified. And this study is really as a follow-up to see how well that hole is healing. So this very dense material here is the contrast that's been drunk. And we can see that within the gastric pull-up. But we can also see that just here, this gap here is the hole in the staple line, and passing through that is this tube that the surgeons have inserted to allow that hole to heal up around the tube. But the contrast is leaked from the GI tract out into this space, and then we can track it all the way along the path of this tube to a drainage bag lying external to the patient. All this way. So giving the contrast enables us to confirm that there is ongoing leak, and it allows us to quantify the size of the hole more accurately, and is very useful to be able to make that diagnosis more confidently. We can also put in contrast into the urinary bladder via a Foley catheter. And one of the times we do this is when people suffer pelvic trauma with fractures to the pelvic bones. And if the CT shows generalized fluid either within the abdominal cavity or around the bladder, one of the questions would be whether or not this patient has suffered a traumatic bladder rupture. So this patient had a previous CT, which I've not shown you here, where there was generalized non-specific inflammation around the bladder. So the question was, is there a bladder rupture? So they've already got a Foley catheter. This is the tube that you can see here passing through the penis, through the prostate, and then this is the balloon within the bladder. We've injected contrast, and you can see this is the contrast within the urinary bladder. And here there's a hole in the anterior wall of the bladder through which this contrast has escaped into the surrounding soft tissue spaces. And we can see on the sagittal view that this contrast is lying in the soft tissue anterior to the urinary bladder, but has not entered the peritoneal space. So this is an extraperitoneal bladder rupture. With an intraperitoneal bladder rupture, what you'd see is that the contrast would have entered the peritoneal space and would be outlining all of these bowel loops, but it's all contained here in the tissues anterior. So it's enabled us to make that diagnosis far more confidently than without administering that contrast into the urinary bladder, and then the appropriate management steps can then be undertaken. Okay, so in this talk, we've talked about when we do a non-contrast CT and the limitations of that type of study. We've covered the various routes of administration of contrast media for CT of the abdomen and pelvis, talked about the different phases when intravenous contrast is used, such as arterial, portovenous, and delayed. And we've talked about the clinical actions that you need to undertake when you're referring a patient for a contrast-enhanced CT of the abdomen and pelvis. Thank you very much.